So I always like to start my talk by telling people about why I'm so passionate about the work that I do, and I do want to give a little bit more about my personal story. So this is a photo of my grandmother, and my grandmother was in her 20s when she was in medical school in Greece. She was one of the only females in her medical school class, and she unfortunately diagnosed herself with breast cancer when she was in her 20s. And it was when they were learning how to do physical exams in medical school. She went on to graduate from medical school and then practice medicine with metastatic breast cancer. Unfortunately, she died just a few years later with metastatic breast cancer, but her story as a physician really left an impact on people in the region. And I grew up hearing her story and wanting to be like my grandma. And then unfortunately, a few decades later, my mother, who was 6 at the time when she lost her mom, my grandma, was diagnosed with breast cancer. And I was in medical school at that time. And there we started the journey of mastectomy, radiation, chemotherapies. And watching her suffer through many of the treatments made me realize that we need to do better for patients with metastatic breast cancer. And so it's the story of these two women that has inspired me to do what I do, which is find better treatments for patients that have cancer that has spread. So let's talk about brain metastases. So brain metastases is when cancer has spread to the brain from other areas. It's actually the most common cancer of the brain. About a third of patients with advanced breast cancer will develop brain metastases. More common in patients that have HER2 positive disease or triple negative disease. And unfortunately, historically, clinical trials in the US have excluded patients that have brain metastases, but that is hopefully changing very quickly. Unfortunately, patients will often develop brain metastases even if cancer outside of the brain can be responding to therapy. And in the last couple of years, we actually partnered with ABTA and did a cross-sectional survey of physicians, patients, and caregivers. And this is something we published last year. And the overwhelming response from the survey was that physicians, patients, and caregivers indicated a significant need for increased treatment research funding for patients with brain metastases and more clinical trial availability. So it definitely is an unmet need, but the community is working towards finding better treatments. So what are some of the symptoms of brain metastases? And it looks like the slides are not quite showing what they're supposed to, but it's okay. So what are some of the common symptoms of brain metastases? So headaches are very common. Stroke is less common. Patients may have seizures. Patients may also develop weakness on one side of their body or the other. The important point is if you do develop new neurologic symptoms or changes, talk to your doctor about it, and it might be worth getting a scan. And how are brain metastases diagnosed? So how do we diagnose them? So typically, we get an MRI with and without contrast. That's usually the study of choice. And the reason why we get an MRI, we prefer an MRI over a CT scan. So here I show you, this is, if you're looking at a CT scan, if you're looking at a brain, looking at it this way, so if you're cutting the brain this way, this is what you would be looking at. So this is a CT scan of a patient, and then this is the MRI of the same patient. And these white spots here are the brain metastases here. And you can see that the MRI is much better than the CT scan for detecting brain metastases. So we tend to prefer to get MRIs when possible. And how do we manage patients with brain metastases? So typically treatment is multidisciplinary. So typically the team that manages your brain metastases, typically the team will consist of a radiation oncologist, a medical oncologist, a neuro-oncologist if there are neurologic symptoms, and often some form of surgery. And let me go through each of these modalities next. So let's talk first about radiation. So historically, radiation called whole brain radiation therapy was really the mainstay of treatment for patients with brain metastases. And this was actually a very old study. I just showed this from 1954, which showed that whole brain radiation can help with symptoms. And this was in 38 patients. In 24 to 38 patients, whole brain radiation helped with symptoms. And this became the standard of care for more than 50 years. And what is whole brain radiation? It's actually what it sounds. So it's radiation to the whole brain. The goals of whole brain radiation are to help with symptoms, so palliation of symptoms, to decrease mortality from neurologic causes, so from a neurologic event. And whole brain radiation helps treat the visible tumors as well as micrometastatic disease. And what does that mean? That means disease that you can't see. And this is just the typical dose. So often this is the dose of radiation that's given, and it's given over 10 to 20 days. Typically, about 30 to 60% of patients do respond to whole brain radiation. And responses are more common in breast cancer and small cell lung cancer, less common in brain metastases from melanoma. And about 25 to 40% of patients have neurologic stability or improvement. However, whole brain radiation does have its toxicities, which is why lots of research is being done now for patients with brain metastases to try to find better treatments for patients with brain metastases. So here are just some of the toxicities, and I'll go through these. So acutely, or in the setting of, when you're receiving the whole brain radiation or within a few weeks of receiving the whole brain radiation, fatigue is the most common symptom. Though hair loss, irritation of the scalp, headaches, loss of appetite, initial worsening of neurologic symptoms, and nausea and vomiting can happen. So this is in the immediate setting. These are some of the toxicities that one may see with whole brain radiation. And then later toxicities include what's called leukoencephalopathy and brain atrophy. And this is it just means damage to normal brain tissue. And this may manifest as memory difficulties later or other neurocognitive issues later. Radiation necrosis, so that's again sort of death of the tissue or inflammation of the brain from the radiation. And I'm happy to talk more about how we manage radiation necrosis later if people have questions about that. Other tumors rarely can happen: stroke, hearing loss, fatigue, damage to the eye, and hormonal imbalance. So these are less common, but these are some of the toxicities, and the risk of these complications are related to the total radiation dose someone has gotten, patient age, the extent of their disease, their neurologic function at time of presentation. So there's different variables that can impact or increase the risk of later complications for the whole brain radiation, but it's often hard to predict who is going to develop those complications. So that's whole brain radiation. There's also now newer, and I'm happy to talk more about this later. There's also newer forms of whole brain radiation and newer treatments that we can try to give to try to help with some of the later side effects. So for example, there's something called hippocampal sparing whole brain radiation, which spares the area of the brain that controls memory. But also there's medications that are being looked at right now to see if they can also help with decreasing some of the later complications or the rate of the later complications of the whole brain radiation. And I'm happy to talk more about that later if people have questions. So let's go now from radiation to surgery. When do we think about surgery for patients with brain metastases? So if patients have what's called a solitary lesion, so one brain metastasis, and if they're feeling well, so they have a good functional status, they can tolerate surgery. If their disease outside the cancer outside of the brain is fairly well controlled, and if there's a need for pathology, those would be reasons to consider surgery for patients with brain metastases. And then if patients have multiple lesions in the brain, then we may consider surgery for the dominant lesion or the larger lesion. If that lesion is causing symptoms and there's significant swelling, then we may consider surgery for that lesion. If there's a large cystic area, and again, if there's need for pathology, if we need pathology for a diagnosis. So these are reasons. This is not an exhaustive list, but these are reasons when surgery may be considered for patients with brain metastases. And what about focused radiation, called stereotactic radiosurgery? And that's being used more and more for patients with brain metastases. So what is stereotactic radiosurgery? So stereotactic radiosurgery, we call it SRS. It's very precise radiation. So it's different from whole brain radiation, which is radiation to the whole brain. This is precise radiation with the goal to preserve normal brain tissue. And it's precise radiation to certain spots in the brain where we see the brain metastases. And so when do we think about stereotactic radiosurgery? So if patients receive whole brain radiation and there are small numbers of metastases that may benefit from focused radiation, then we sometimes think about SRS there. It's often used as an initial therapy for limited number of brain metastases. So if a patient has a couple brain metastases, stereotactic radiosurgery can be very effective. And now there are clinical trials looking at using stereotactic radiosurgery for larger numbers of brain metastases. It can be used to salvage, meaning for therapy, for recurrence after initial therapies, then SRS can be used there. And we often consider it for patients that receive surgery as what's called a boost to the surgical cavity. So if you receive surgery, then we usually go and do radiation to the area where you got the surgery in order to decrease the risk of recurrence locally in that area. And the control rate, or the local control rate, is 70 to 90%. So it's quite effective. So what are some of the ideal targets? So when we think about radiosurgery, so the focused radiation, what are some of the targets that we're looking for? So if the spot itself, the metastasis, is well defined, if it has a certain shape, if it's smaller, so less than 4 centimeters, and if they're not infiltrating into the brain. So these are ideals of characteristics that would make us think maybe SRS is the right thing to do. Once they get larger, so more than 4 centimeters, then we often then do lean more towards doing surgery for those cases, particularly if a patient is having symptoms. And then what are some of the pros and cons of surgery versus stereotactic radiosurgery? So surgery allows, as I mentioned, it allows us to treat the larger lesions. It helps us rapidly resolve mass effect. What is mass effect? It's if the lesion is large and shifting things in the brain, surgery may help with that, helps remove the cancer. It helps us confirm the pathology or the diagnosis. Often patients who have brain metastasis are on steroids to help with the mass effect, or to help with the swelling in the brain. And I'm happy to talk more about that later too. So surgery helps with being able to decrease that dose of steroids that patients may be on. And also there's a lower risk of radiation necrosis. And radiation necrosis, as I mentioned, is inflammation from radiation or damage to the brain from the radiation. Stereotactic radiosurgery allows the treatment of smaller, more difficult to resect or more difficult to take out lesions. It's more minimally invasive, so it's not brain surgery. There's no general anesthesia. It's an outpatient procedure. More than one spot can be treated during the same session, which is harder to do with surgery. There's a short recovery time, and it also allows more rapid initiation of treatments, of if chemotherapy needs to be started or other treatments. So let's briefly talk about targeted therapy and what role that targeted therapy may play for patients with brain metastases. So what is targeted therapy? It's therapy where we can actually, so in general, precision medicine for oncology, we do genetic testing of a particular tumor, and then we can pick a therapy that can target that specific genetic change. So HER2 amplifications, for example, as you all know, the HER2 agents target the HER2 amplifications. And that's really revolutionized the management of cancer. And in the last several years, there have been a number of targeted therapies that are being looked at for patients with breast cancer brain metastases. And so here are just some examples of some of the clinical trials that have looked at targeted therapies specifically for patients with breast cancer brain metastases. And I'm focusing more on HER2 here. So this was a study, and again, I want you to focus on here the drug itself and then response rates in the brain, meaning the percent of patients that have responses. So lapatinib is a HER2 agent. In this clinical trial, when it was looked at on its own, only 6% of patients responded, in the brain. But when it was looked at in combination with this drug, capecitabine or Xeloda, which is known to have activity in the brain, the response rates were actually 65%, so improved. So about 65% of patients had responses in the brain. There's another HER2 drug called neratinib. Again, when it was looked at on its own, so just focus again on this column, the response rates. The response rate was 5%, but when looked at in combination with capecitabine, response rate was 49%. And then looking at this newer drug, which is quite exciting for the field for patients with breast cancer brain metastases, tucatinib is another HER2 agent. And then when looked at in combination with trastuzumab and capecitabine, and then compared to placebo trastuzumab capecitabine, the response rates were 46% in the brain, patients who got the triple combination, so tucatinib, trastuzumab, capecitabine, versus placebo trastuzumab capecitabine, where the response rate in the brain was 20%. So there are newer agents now that are being looked at in clinical trials to improve upon this, because we obviously need to do better. So I know this is a busy slide, and let me walk you through this. So in the past, when we thought about the management for patients with brain metastases, almost every patient received whole brain radiation. And as I had mentioned earlier, whole brain radiation can have side effects. So now that's very quickly changing. So now when we have a patient who presents with a newly diagnosed brain metastasis, the first thing we ask is the patient having symptoms? And if yes, then we consider a local therapy with surgery or radiation, whether it's stereotactic radiosurgery or SRS, whole brain radiation. And that does depend on the number of spots and the amount of mass effect. So that decision depends on a few things. And then the decision for what systemic therapy to treat patients with depends on various factors. And so, there's a lot of nuances to that I won't go into detail today, but it does include the status of both the intracranial and extracranial disease, how a patient is doing, the molecular profile of the cancer, et cetera. So let's go back now. So if the patient is not symptomatic, then we consider systemic therapy if there's a known active drug with activity in the brain. So CNS is central nervous system. So if there is a known active drug, then sometimes we'll try to, if the lesions are small, if the brain metastasis lesions are small and the patient is not having symptoms, then sometimes we will consider systemic therapy for patients. And then if they do progress, and this is just the name of IRANO criteria here, you'll see it's just the name of the criteria we use for defining the progression for patients with brain metastases. So if they do progress, then again, we ask that same question. If the patient is symptomatic, then we reconsider surgery and stereotactic radiosurgery. And then again, that decision for the systemic therapy or for the treatment, either chemotherapy or targeted therapy, really depends on a variety of factors. If the patient is not progressing, then we continue the systemic therapy. And then back to if the patient is progressing and the patient is not symptomatic, then we do consider switching systemic therapies if the patient does not need urgent surgery or stereotactic radiosurgery, and there is an effective drug option that has activity within the brain, that has known activity in the brain. And then the other important point is that any point during progression, we do consider clinical trial options particularly if there is a patient that has had surgery for their brain metastasis, then we do recommend doing genetic testing of that brain metastasis to see if there are other treatment options. So this obviously is just a very general schematic we use for the management, but it doesn't capture the nuances for each individual patient. But this does give you a sense of what are some of the things we think about when we're managing patients with brain metastases. Let me now go into some of the research we're doing in this area to show you that I think there is a lot of hope in this area, that in the next few years, I hope we will see improved treatment options for this area. So what are some of the unanswered research questions? Number one, what are the targetable mutations in brain metastases? And as I had mentioned at the beginning, patients will often progress in the brain, but not outside of the brain. Can this be due to genetic changes that are different in patients with brain metastases compared to their original primary tumors? And then the last question is, can we rely on the original primary tumor to make decisions for targeted therapies for patients with brain metastases, which is what's often standardly done? And actually, the research that I'm going to present now, some of it was funded by the American Brain Tumor Association when I was starting out as a fellow and then a junior faculty member. So let's go into the biology of brain metastases to help you understand what we're trying to do in the lab. So this schematic here shows you all the steps that need to happen for a brain metastasis to get to the brain. So the cancer cells need to grow. So they grow in the breast. Then they need to invade the tissue. They need to then get into the bloodstream, survive in the bloodstream. They need to stop in the brain and then grow in the brain and then develop new blood vessels. So cancer arises from the acquisition of genetic changes or mutations in the DNA of cells. And changes in the DNA may contribute to each of these different steps. And if we can identify these genetic changes, we may be able to target and stop the cancer from metastasizing. So that's the goal. And we don't yet understand all the different changes that need to happen, the genetic changes for the brain to actually, for the metastasis to set up shop in the brain. And so our goal is to change that. So we've now built a clinical and translational scientific center at MGH Cancer Center to study brain metastases. So we have a multidisciplinary brain metastasis clinic. In the lab, we do molecular studies to try to understand, again, how and why cancer is spread to the brain, with the goal to take as much to clinical trials as possible and bring that back to the clinic. Again, some of this early work was funded by ABTA and other philanthropic organizations, and we're really grateful for that. So one of the first steps of this program is to detect those genetic changes in the DNA of the brain metastases. So as I had mentioned, the multiple steps needs to happen for the brain metastasis to occur. So we're trying to understand what are those different genetic changes at each of those steps. So prior to this study, the largest study in brain metastases had looked at that comprehensively characterized all the genes, had one patient sample. And our goal was to really change that. And so in the last several years, we've established this massive collaborative effort, both institutions in Boston, but as well as throughout the world, where we're actually collecting tissue samples from patients with brain metastases. And we're using the most powerful state-of-the-art technologies at the Broad Institute at MIT to try to analyze those samples. So we now have more than 1,500 patient samples that we're in the process of analyzing. And we have collaborations from all over the world, and patients have been graciously consenting for these research efforts. And we're now trying to characterize the brain metastases, again, comparing to the primary tumors to see how they're different and to see if we can identify potential new targets for patients with brain metastases. And so we have this very large tumor bank now that we're working with, which is really exciting. So as a first step of this study, we actually conducted a large genetic study looking at brain metastases, and this included patients with breast cancer, lung cancer, melanoma, and other cancers, where we looked at 104 brain metastases, so tissue from brain metastases, matched with primary tissue and as well as normal tissue, so normal lymph nodes or blood. And let me talk a little bit more about the science that we've done. So the goals of our research is to understand, as mentioned, the genetic evolution leading to brain metastases, with the major goal to identify drug targets and improve therapies for patients with brain metastases. And let me walk you through this slowly. So for each matched brain metastasis and primary tumor, we map out the genetic or evolutionary relationship, meaning we try to understand where different genetic changes happen. Do they happen in the brain metastasis, as depicted here by the red? Are they in the primary tumor, as depicted by the blue? Or are they shared, as depicted by the gray? And what we found was that patients with brain metastases, so when we looked at the brain metastases and primary tumors, there were some shared mutations. The brain metastases and the primary tumors shared some mutations, but then there were new mutations in the brain metastases. So you can look at the schematic here, what I mean here. There were new mutations in the brain metastases that we did not see in the primary tumor sample. So why is this important? Well, it's really important to know if therapeutic targets are different in the brain compared to the original primary breast cancer. And I actually like to show this figure. This was from Charles Darwin in 1837, where he actually mapped out branched evolution here. And actually, this is the pattern we see in brain metastases. We see this branched evolution pattern in the genetic changes. So let me take this back to some clinical examples. So do brain metastases, the tissue samples harbor targetable mutations that are absent from the original breast cancer? And I'll show you this one example here. So this is a patient that had a HER2 positive breast cancer that had a brain metastasis while on trastuzumab therapy, and the disease outside of her brain, so her cancer outside of her brain, was well controlled on the trastuzumab therapy. And what we found was that the brain metastasis in the primary tumor, so it shared these common mutations here. So these are the mutations that were shared. So ERB2, that's HER2, it was shared. But we found a targetable mutation in the brain metastasis. So we found this EGFR mutation in the brain metastasis that was not present in the primary tumor. And this is actually the same mutation that we see in lung cancers and predicts sensitivity to some of the EGFR inhibitors that are used in lung cancer. It hasn't really been described in breast cancer, but surprisingly, we found it in the brain metastasis of this patient. And here I just show you a schematic what I mean. So this EGFR mutation was in the brain metastasis, but not in the original primary tumor. And then when we looked across all the different cases of brain metastasis, we actually found that more than half of the cases had targetable mutations in the brain metastasis that we didn't see in the original primary tumor. So here's a histogram of all the different clinically actionable alterations we found, and the colors represent what branch they occurred on. So more than half the cases had a clinically actionable alteration in the brain metastasis that was not detected in the primary tumor. But importantly now, so I've just told you about all the genetic differences between the brain metastasis and primary tumor. Were there commonalities? So we can start thinking about clinical trials for patients with brain metastases. And indeed, there were. So we found, for example, more than half the cases had alterations in a pathway called the cyclin-dependent kinase pathway. And actually, CDK inhibitors are already FDA approved for the use in breast cancer. So we found that more than half of the cases of patients with brain metastases very commonly had CDK pathway alterations. And about 43% of cases had alterations in the PI3 kinase pathway, and PI3 kinase inhibitors are also in clinical investigation and in clinical use in cancers, including breast cancer. So these were both very common pathways that were common in patients with brain metastases. And based on this work, we've now initiated a biomarker-driven trial for patients with brain metastases, meaning we do genetic testing of if there is brain metastasis tissue available for genetic testing, we do genetic testing of the brain metastasis. And if they have specific genetic changes, then then patients are treated with that specific inhibitor. And this trial is actually open at more than 100 sites throughout the US. It's a national trial. If you're interested in this trial, feel free to send me a note. You can also look for more information on clinicaltrials.gov for this particular trial, but it is a biomarker-driven trial, and it's actively enrolling patients now. So the question we're still trying to answer is, if we target those genetic changes that are in the brain, will that help improve outcomes for patients with brain metastases? And that's the ongoing question that we're trying to answer. So just to put everything together, so we now have a multidisciplinary brain metastasis tumor board, which includes multiple disciplines. And this is, again, to emphasize the fact that the management for patients with brain metastases is very multidisciplinary. If you're very interested for coming for a second opinion to our clinic, here's the number here, and we're happy to see you and discuss your case. And then here's just a link. You're probably all very familiar with this, but how do you find clinical trials nationally? So www.clinicaltrials.gov. I just showed you one example of our biomarker-driven trial, but do look at clinicaltrials.gov for other clinical trial information. And how to find out more information about our research. So here's the link for our lab. So in conclusion, care for patients with brain metastases is multidisciplinary. There is a lot of exciting research being done in brain metastases, and I only scratched the surface with some of the work we're doing, but there's others that are doing really exciting work. We're now conducting a very large genomic study for patients with brain metastases. If you are interested in participating in the genomic study, or if you'd like your tissue samples to be used for our study, please do shoot me a note. What I hope I showed you today is that we do find targetable mutations in brain metastases. We did show in our research that brain metastases can have different targetable genetic alterations compared to their primary tumors, which we're now exploring the significance of this in clinical trials. And brain metastases clinical trials are now underway. And I always like to end my talk. My mother died, unfortunately, in 2014 from metastatic breast cancer, and I miss her every day. She won't live to see her grandchildren. I'm 8 months pregnant now, and she won't live to see this research unfold. And before she passed away, she made me and my brother promise that we would commit our lives to finding better treatments for patients with cancer, and that's what I'm dedicating my life to. So I will end my talk here, and I'm looking forward to getting questions from the audience.
Thank you so much, Dr. Brastianos, and also really appreciate you sharing your personal story and learning more about the influence your mother and your grandmother have had on your research. So we really appreciate you sharing that. So we already have a number of questions, so I'm going to jump in. We've got about 15 minutes. So the first question actually kind of relates to the research you were just discussing. If you don't have a brain tumor tissue sample to test, are there any other ways to molecularly profile a brain metastasis?
That's a wonderful question, and that's very much an active area of research. So one thing we are looking at right now is, and I didn't have time to go into that, is we're looking to see if we can use DNA or cell-free DNA from the spinal fluid to see if that can serve as a surrogate for what's in the brain. So and what we're finding some of the and so it's again it's research only. We're still obviously it needs to be looked at a larger scale. But what we are finding in the research is that the cell-free DNA from spinal fluid does look more like the brain metastasis compared to if we were just to look at cell-free DNA from blood. And what is cell-free DNA? It's it's the cancers can shed DNA into the blood or into the spinal fluid. So so we are looking to see if there's non-invasive ways to measure that. So that is an active, very important question that needs to be answered, because obviously surgery can be quite invasive. So if we can find a non-invasive way to do that, that would be ideal. So CSF is one thing we're looking at. And then we're also looking to see how well blood cell-free DNA can also look like the brain metastases, which, some of the early work we and others have done, there are some similarities, but there are some differences between the blood cell-free DNA and the brain metastasis. So, so that's work to, that still needs to be investigated, but it's a really good question. And certainly in some of our other trials, again, I didn't have a chance to talk about that. We are looking, also if the patient does not have brain metastasis tissue, we also look at metastases from other sites too. So that is an ongoing question too.
Wonderful. Thank you. So maybe some opportunity there for people to participate in clinical trials that might be looking at that question.
Exactly.
Another question is if you can speak to some of the first signs and symptoms someone might see for retinopathy and about vision changes that you might experience from whole brain radiation.
I think for any concerns you have, just stay in really close contact with your doctor. So if you do have, visual changes, if you develop blurry vision, do let your physicians know. Reach out to your radiation oncologist, and then see an eye doctor. So just stay and this pertains to, so if you develop any neurologic symptoms, either if you've never been diagnosed with brain metastases, but you do develop neurologic symptoms, as I mentioned, do talk to your oncologist. And then also after you've gotten treatment, stay in close contact with your physicians about any of these symptoms. So if you develop blurry vision, or if you feel like your eyes feel irritated, or if you any symptoms that you're concerned about, do talk to your doctor. Always err on the side of talking to your doctor about any symptoms. As physicians, we'd rather hear from you than not hear from you. And if we don't hear from you, we don't know if there is anything wrong. So absolutely stay in close contact with your radiation oncologist. And then, you can get eye exams, or, the retinopathy and any other damage to the eye can be evaluated with eye exams. Either typically you would see an ophthalmologist for that.
Okay, thank you, Dr. Brastianos. So I have a couple other questions about different kinds of side effects. One is about how you approach steroid treatment for edema or inflammation from whole brain radiation. How long do you keep a person on steroids, and how do you taper them off?
Yeah, and we can talk about steroids in general for management of brain metastases too, or so that's a really good question. So number one, why do we use steroids for management of patients with brain metastases? So steroids can be very effective at reducing the swelling around a brain metastasis. So brain metastases can have a lot of swelling around them just by their nature. They have a lot of swelling, and they can cause symptoms. And so when patients develop symptoms from that swelling, that would be a reason or indication to start steroid treatment. So steroids can be very effective at that. However, we try not to keep patients on steroids for very long when possible, because steroids, if you're on them for a long time, can have long-term side effects. So in the short term, They can be very effective, but then in the long term, particularly higher doses of steroids can have side effects. So we try to decrease the steroids as we can. And what do I mean by that? So we go by how patient is doing. So for example, if a patient has a large brain metastasis and has a lot of swelling around the brain metastasis, and the patient has lots of symptoms, and then the patient goes to surgery for that brain metastasis, then the surgery has now removed that swelling around the brain, and then we try to taper the steroids. And how quickly we taper really depends on many factors. So there's no one formula, which is why it's hard to answer the question, we treat the patient for X number of days with X dose, because it really depends on the patient, how the patient is doing, how the symptoms are doing, and what treatment the patient got for their brain metastases. In some cases, we need to treat a patient with very high doses of the steroids in order to keep that swelling down. And that will be a different taper compared to the patient who's on a low dose of steroids for fewer symptoms. So the answer, the quick answer is we try to taper the steroids as safely and as efficiently as we can while managing the patient with their symptoms. And that same goes for in the setting of radiation too. So whether it's with whole brain radiation or with stereotactic radiation, it depends on the amount of swelling, how symptomatic the patient is, and how quickly the symptoms have resolved with the radiation too. And then we work really closely. We'll often see patients once a week while we're trying to taper those steroids to try to get you off the steroids again as quickly and safely as we can. So sorry, that was a much longer answer because there's a lot of nuances to that. But we do try to take people off. We try not to keep people on steroids chronically unless they need to be on those steroids chronically.
Thank you for that answer. Another person is asking about whether you prescribe medication to prevent long-term cognitive changes from radiation treatment. And she's asking about a medication called memantine, which I think is given for dementia or Alzheimer's disease.
Yeah, that's a wonderful question. And I did allude to that a little bit earlier in my talk too. So, there's emerging data now that there are ways we try to minimizing some of those neurocognitive side effects. One of them is to do what's called the hippocampal sparing radiation that I talked about, which is protecting those memory areas. And that in combination with the Namenda, there is data showing that can decrease some of the rate of the neurocognitive side effects that we see, or the decline that we see. So Namenda is commonly used, and it's a very reasonable medication to consider, particularly in certain patient populations. One, if you are concerned about the neurocognitive, the risk of the neurocognitive decline, the data, there's still clinical trials evaluating that, but the clinical trials that have looked at that, there are some encouraging results from doing the hippocampal sparing with the Menda in combination.
Are there any traits about the person being treated that would influence whether they have more cognitive side effects from these types of therapies, like age or?
Yeah, that's a great question. So age is a big one. And they right now, and this is an area of research right now, is trying to predict who will develop the neurocognitive side effects. Age is a big one. So the older you are, and by meaning the older you are, you're over 65 in general, then we worry a lot more about the cognitive side effects. And in particular, if we can, we'll try to avoid whole brain radiation if possible in older patients, because there we do see, there is a higher risk there when it comes to age. There are, unfortunately, in the past, when these clinical trials of whole brain radiation were done, neurocognitive toxicities or cognitive, looking at the cognition in patients wasn't routinely done, and unfortunately, and it's terrible because a lot of these clinical trials did not evaluate that. But now, with more awareness in the last 1 or 2 decades, that's definitely been an area that people are studying more and more. So I hope in the next few years we'll have a lot more data about that particular area to know, if we could predict who's going to develop those toxicities, obviously, then we would try to minimize when we can. But I also do think that some of the newer radiation techniques are also showing, encouraging results too. Again, trying to spare those areas that do control memory.
Thank you. Our next question is from someone asking, if SRS is successful, how likely are mets to return to the brain?
That's a really good question. And the answer is, in terms of local, so there's a couple things there. So SRS is used to, you're targeting that specific metastasis that you're targeting with the radiation. So it's not like whole brain radiation. If there's a specific metastasis, you're targeting that metastasis. The control rate in general, from the studies that have been done, the local control rate for SRS, so the control rate for that spot that you're radiating, is about 70 to 90%. However, that doesn't necessarily impact the distal control rate, meaning, unfortunately, you can still get metastases in other places in the brain. And the risk of that, there really depends on a number of factors, and it depends on the extent of your disease, depends on the sort of molecular profile of your disease, depends on a lot of things, depends on how aggressive the disease is. So that piece, it's harder to predict. We know that for the lesion that the SRS treats, there's a control rate of 70 to 90%. And as I had mentioned earlier, with SRS, you can give it to multiple lesions. So, and there are studies now trying to evaluate what is the limit of those number of lesions, like how many can we actually treat? Because in the past, it would be reserved for 2 to 3 lesions, but now we can do more lesions of that with stereotactic radiosurgery. And over time, so you may have a brain metastasis diagnosed at one point, and then 2 years later have another brain metastasis diagnosed that did not get stereotactic radiosurgery, and then you can get stereotactic radiosurgery to that spot 2 years later, and then to another spot 6 months later. And the radiation oncologists, they look at their radiation plans and try to figure out how safe it is to give more radiation to that area.
Great. Thank you for answering that question. So I'm going to ask the last question, unfortunately, because we're almost at the end of our hour together. Would you comment on regularly screening people with metastatic breast cancer for developing brain metastasis rather than waiting for symptoms to appear? This is obviously, we get this question very frequently. Why aren't we scanned? Why can't we be monitored? And would really be interested in your insights on that.
Yeah, I think that's a great question to which we don't have a good answer. I'm a brain metastasis specialist, so more data for me is better, and early detection would be wonderful. I think there needs to be more clinical trials to actually evaluate that question. Meaning, if we can, if we scanned all patients with brain metastases, would that improve outcomes? So I do think that this is an area that needs to be studied. That absolutely needs to be studied. Because the question is, if we can detect patients with brain metastases earlier, will that improve outcomes? So that's such an important question, and I think as a field really needs to be studied. To try to figure out when should we be getting these scans, at what point in the disease course, what are the patients that we should be scanning? And I think that's it's an unanswered question, but I think is so important.